I'm Michael Price's avatar. He's currently helping clients manage their GSA and VA contracts, and he reads every comment. Welcome. I'm Michael Price, your host.
And I'm Nancy, your co-host.
What if I told you that the hardest part about getting the most popular weight loss drug in the world isn't actually paying for it?
Oh, yeah.
It's actually knowing the secret password to unlock your own medical file.
Right, which is the reality for thousands of veterans right now. When you're standing on the outside of this massive bureaucracy like the Veterans Affairs healthcare system, it just feels completely random.
Completely.
You see one veteran get a highly sought-after medication approved in a week, and then another veteran spends like 6 months fighting for the exact same drug.
Just to be denied.
Exactly, only to be denied. And it creates this illusion that the system is just an impenetrable wall.
And that illusion leads to so much frustration for you guys listening. You assume getting what you need is just about yelling at the gate loudly enough or, throwing paperwork over the brick wall and just hoping something comes back.
Yeah, throwing spaghetti at the wall.
Exactly. But when you start digging into the actual policies, you realize that Fortress isn't random at all. It is highly engineered. The gates aren't locked to keep you out. They just, they simply require a very specific, perfectly cut key to open.
Beautifully put.
And today, for you listening, our mission is to hand you the literal blueprint to cut that key. We're navigating the VA system to access those massively popular GLP-1 medications, specifically terzepatide.
Which is a subject that is absolutely fraught with misinformation right now. The rumors and the anxiety surrounding this medication are just at an all-time high.
To cut through all that noise, we're pulling from a really fascinating stack of sources. We have a detailed set of policy notes from the 6th of August 2026, and this incredibly insightful breakdown from a YouTube creator named Bill, who goes by the Salty Old Marine.
A great channel, by the way.
Really great. So we are going to build an actionable blueprint by looking at the VA Formulary Advisor, unpacking the rigid requirements of the MOV program, and examining the medical hard stops that just cannot be negotiated. Okay. Let's unhack this because the very first hurdle most people hit is a fundamental misunderstanding of how the VA classifies this medication.
Yeah, the classification is definitely the perfect place to start. The VA is not just throwing up arbitrary red tape to be difficult or even just to save a few dollars. They operate on a very strict internal logic.
Right.
And that internal logic dictates that approval is based entirely on the diagnosis you present with rather than the drug itself.
That is the biggest point of confusion, I think. Let's talk about terzepatide for a second. That is the active molecule. It is manufactured by the exact same company, put into the exact same injection pen, and yet it's sold under two entirely different brand names, Mounjaro and Zepbound.
Right. From a purely chemical and biological standpoint, Mounjaro and Zepbound are identical.
Like zero difference.
Zero difference. If you held the two pens in your hand, the liquid inside does the exact same thing to your body. But from a bureaucratic and diagnostic standpoint within the VA, they are treated as two entirely distinct entities.
With completely different rules for access.
Exactly.
So let's try to visualize this because it is just so vital to understand. Imagine dealing with the VA as like trying to get into a really exclusive VIP club, but there are two different doors you can walk up to.
Okay, I like this.
Door A is Mounjaro. This is the pathway for type 2 diabetes. In this scenario, the bouncer doesn't really care how you look. They just want to see your specific ID. They're looking for evidence, like an A1C blood test above a certain threshold, proving that your current cheaper medications just aren't working.
Right? Like if you're on metformin or Jardiance and your blood sugar is still out of control, you have a solid case.
Exactly. It requires prior authorization, but the bar you have to clear is entirely tied to your blood work. It has absolutely nothing to do with your body mass index or your BMI.
And we can look at the medical necessity behind that. The clinical term here is acute metabolic management. Uncontrolled type 2 diabetes is a true immediate crisis.
Because it's actively damaging your body, right?
Yeah. High blood glucose acts almost like microscopic shards of glass in the bloodstream. It is actively and rapidly damaging blood vessels, nerves, the kidneys, the eyes. The VA needs to arrest that damage immediately.
So they open door A pretty quickly if you have the right blood work.
Precisely. The lab values speak for themselves, so the approval process is streamlined to put out that fire as fast as possible.
But then you have door B. This is Zepbound, the pathway for weight management. And the VA bouncer at this door is way, way stricter. This is where veterans are getting stuck. So my question is, if it's the exact same medication, Why does the VA treat a veteran at the weight management door so much more strictly than a veteran at the diabetes door?
Well, it really comes down to how large medical systems triage long-term chronic conditions versus acute crises. When Zepbound is prescribed for chronic weight management alone, the VA shifts to a totally different protocol.
Because it's not seen as an immediate fire.
Right. They view weight management as a progressive foundational issue. It causes damage over years, not minutes. Therefore, the VA requires veterans to prove that they have exhausted all the lower-cost behavioral routes first before they authorize an expensive, highly specialized medication.
Like trying diet and exercise before turning to a drug.
Exactly. They want to see what we might call sweat equity. They want proof that you've put in the work on the foundational lifestyle habits before they hand over this premium tool.
Okay. Since the VA demands that foundational work and that sweat equity, it implies there's a specific set of rules governing what that work actually looks like.
Yes, there is.
And the incredible thing we learned from the salty old Marine is that veterans don't actually have to guess what those rules are. These are not classified documents hidden in a vault somewhere.
No, and that is perhaps the most empowering piece of information we can offer today. The VA operates on a formulary, which is basically their official list of approved drugs and the rules for prescribing them. And the rules governing that formulary are entirely transparent. Well, if you know where to look.
So let's give you the actionable steps right now to find the literal cheat sheet your doctor is using. You go to the website va.gov Formulary Advisor. That's all one word.
Highly recommend writing that down.
Definitely. So when you get there, you use the search bar, but you do not type in Mounjaro or Zepbound. You type in the active ingredient, which is terzepatide. Because they're the same molecule, that one search brings up the results for both brand names.
And once you execute that search, you are looking for a very specific set of documents labeled criteria for use. I really cannot stress this enough. This document is the exact same set of guidelines that your VA provider is looking at on their computer screen during your appointment.
The salty old Marine gives a fantastic piece of advice here. He says to pull this document up before your appointment, read it, know which boxes the doctor has to click on their screen to get your request approved.
Yeah. Going in cold and just demanding the drug is a recipe for a denial. But pulling this up beforehand shifts the entire dynamic of the doctor-patient relationship. It moves from an adversarial interaction where you are demanding something and the doctor is guarding it, to a collaborative one.
Because you're both looking at the same map.
Exactly. When you know the criteria, you can actually help your provider build the clinical case for your own approval.
It's essentially an open book test. You have the answers right in front of you. But I do want to push back on this a little bit.
Okay, sure.
Because even an open book test is pretty useless if it's written in a foreign language. A lot of medical documents are dense. They're filled with jargon, and they can be incredibly intimidating for a layperson. If I pull up this criteria for use document, what exactly am I looking for?
That is a very fair concern. Medical documentation can definitely be opaque, but the surprising thing about these specific VA documents is how functional they are. Yeah, they are essentially flowcharts. If you are looking at the weight management side, the Zepbound side, the document strips away a lot of the jargon. It will explicitly ask for two major things to be documented in your file.
Which are?
A specific body mass index, or BMI, and documented participation in a comprehensive lifestyle program.
Okay, let's decode this stricter path, starting with that BMI requirement. To even be considered for Zepbound for weight management, the flowchart says you need a BMI of 27 or higher.
Correct.
Now, you listening, you do not need to pull out a calculator and do the math yourself. You can find this number easily in your digital health records. If you log into the My Health Vet portal and download your blue button report, your most recent BMI from your routine checkups will be listed right there.
It's very accessible.
But a BMI of 27 isn't remarkably high, is it? I mean, it doesn't sound extreme.
It is not. A BMI of 27 actually places a patient in the overweight category, but it falls short of the obese category, which begins at 30. Because 27 is relatively low on the scale, the VA dictates that this number alone is not a golden ticket. To justify the cost and the intervention, that BMI must be accompanied by at least one weight-related health condition.
Which the medical community refers to as a comorbidity.
Precisely.
The sources list some specific examples that qualify as a comorbidity for this pathway. Things like hypertension, which is high blood pressure, sleep apnea, osteoarthritis, prediabetes.
And those specific conditions are listed because they are direct mechanical or metabolic consequences of excess weight. Relieving the weight mechanically relieves the pressure on the airway in sleep apnea or, the load on the joints in osteoarthritis. The VA needs to see that compounding factor.
So if a veteran checks their blue button report, sees a BMI of 27, and has hypertension on their record, they've checked the first massive box.
Yes, they have.
Which brings us to the lifestyle program. And this is where the VA demands to see that sweat equity we talked about before they prescribe the medication.
And this is arguably the most labor-intensive requirement. The official term is a comprehensive lifestyle intervention, or CLI. For the vast majority of veterans, this requirement is fulfilled by participating in the VA's MVE program.
That's MVE with an exclamation point, which always sounds very enthusiastic. But they weren't just looking for a veteran to say they, tried to eat a salad a few times a week.
Far from it. To satisfy this requirement, your medical records must show documented participation in 3 very specific areas within the past year.
Okay, what are the 3 areas?
First is diet, meaning you received formal nutritional guidance and implemented dietary changes. Second is physical activity, showing you incorporated, structured, regular exercise. And the third, which is often the most challenging, is behavioral change.
Let's unpack that third pillar. Why is behavioral change explicitly separated from diet and exercise?
Well, we have to look at the psychology of weight management. Terzepatide is an incredibly powerful tool. It mimics hormones that signal to your brain that you are full, and it slows down digestion. It physically suppresses your appetite.
But it doesn't change how you think.
Right, the drug does not cure emotional eating. It does not teach you how to navigate a grocery store or how to cope with stress without turning to food. The VA requires documented behavioral change because they want proof that you are building the mental infrastructure to support the physical effects of the drug.
That makes the sweat equity concept much more understandable. They really want that foundation built.
Exactly.
But here's where it gets really interesting. In reading through the source materials, I noticed a massive gray area.
Oh, yeah.
The guidelines list those 3 pillars: diet, exercise, behavioral change, and they say it must be documented within the past year. But they do not give a minimum time limit for the MVE program. There's no strict rule saying you must attend for exactly 12 weeks or complete 10 sessions.
No, there isn't.
Doesn't that leave a lot of gray area for the local VA facilities to just decide on a whim what completed actually means?
What's fascinating here is that you have hit on the exact friction point of decentralized healthcare. The national guideline provides the framework, right, documented within the past year, but the operational reality of how that metric is fulfilled is left entirely to the directors of the local VA hospitals or clinics.
Wow, so it varies.
Heavily. One VA facility in Florida might consider 3 consultation appointments with a nutritionist to be sufficient documentation. Another facility in Ohio might require a full 12-week rigorously supervised program before they will check that box on their screen.
Which explains the salty old Marine's advice perfectly. He stresses having a direct, frankly blunt conversation with your local VA provider. You have to ask them directly, like, "Doctor, what does this specific facility consider to be satisfying the MOWV requirement?"
Because you cannot assume your buddy's experience in another state is going to match your experience at your local clinic.
Right. You have to understand the local interpretation of the national rule. Otherwise, you might spend weeks doing something that doesn't actually count towards your approval at your specific facility.
It's a huge pitfall, yeah.
So let's play this out. A veteran does the groundwork. They pull up the formulary advisor. They check their blue button report. Let's say their BMI is 29 and they have sleep apnea.
Okay, they have the comorbidity.
Right. They go to their local VA. They complete that facility's specific version of the MOVE program, and it is all properly documented in the past year. The boxes are checked. The VIP doors should open, right?
Not quite.
Wait, really?
Yeah. Even if you have perfectly prepared your file and navigated the bureaucracy flawlessly, biology might still stop you. There are still absolute roadblocks you cannot negotiate your way out of. We call these the medical hard stops.
Oh, this is a crucial shift in the conversation. We aren't talking about policy anymore. We are talking about physical safety.
Yes, there are certain conditions that will cause a provider to immediately halt the prescription of terzepatide, regardless of whether you need it for diabetes or for weight management.
Okay, what are these universal disqualifiers?
The primary one is a personal or family history of medullary thyroid cancer. If that specific type of cancer is anywhere in your family tree, the door is definitively closed.
No exceptions.
None. Another absolute hard stop is a known pregnancy.
And the sources also list a history of pancreatitis, severe gastrointestinal issues, and certain stages of diabetic eye disease, right?
Yes, those are massive stop signs as well.
Now, the notes suggest there is a tiny bit of wiggle room with the GI issues and the eye disease. Like it's a huge red flag, but if the doctor thoroughly documents a clear risk-benefit conversation with you, they might proceed.
That's true, but generally, providers are extremely hesitant.
And we need to break down the mechanism here. The VA is throwing up red flags, but what is actually happening in the body? Let's take the gastrointestinal issues, for example. Why is that such a problem?
To understand the red flag, you really have to understand how the drug functions. GLP-1 medications work in part by delaying gastric emptying.
Meaning?
This means they intentionally slow down the rate at which food leaves your stomach, which keeps you feeling full longer.
Oh, okay.
So if a patient already suffers from severe gastrointestinal issues like gastroparesis, which is essentially partial paralysis of the stomach, introducing a drug that further slows digestion could be catastrophic. It could lead to severe blockages, intractable vomiting, and hospitalization.
Oh, wow. So it's exacerbating an existing problem. And what about the pancreas? Why is a history of pancreatitis a hard stop?
Well, these medications also interact directly with the pancreas to stimulate the release of insulin. If a patient has a history of pancreatitis, their pancreas is already prone to severe inflammation. By introducing a drug that heavily stimulates that organ, you are essentially overworking and damage the system. You are lighting a match in a powder keg.
Hearing the biological mechanisms makes me wonder about the motivation, though. Is this just the VA being overly cautious to save money? Like, are they just using these medical conditions as a convenient excuse to deny a drug that costs $1,000 a month?
If we connect this to the bigger picture, we can definitively say this has nothing to do with VA penny pinching. Truly, these hard stops are not VA bureaucracy. They are built directly into the medication's FDA safety profile. These rules apply whether you are a veteran at a VA clinic or a billionaire paying out of pocket at a private clinic in Beverly Hills.
Wow, okay.
The strictness here is purely about patient safety. The provider is protecting you from a potentially fatal adverse reaction.
That completely changes the whole dynamic of a denial. If a veteran gets denied because of a hard stop, it's not the VA trying to save a buck, it is the doctor trying to save their life.
That is the core of the issue. Safety always overrides access.
So synthesizing everything we've pulled from the salty old Marine and the 2026 policy notes, what does this mean for you, the listener, trying to navigate this system today? The core message is preparation. Do not walk up to the fortress gate and just start demanding entry.
Right. Do not walk into your VA appointment cold.
Exactly. Preparation is your greatest advocacy tool. You need to know which pathway you are on. Are you dealing with a kitchen fire on the diabetes pathway, relying on lab work and A1C? Or are you fixing a leaky roof on the weight management pathway?
And if it's the latter, you have to do the foundational work.
Yes. Go to vafi.gov formulary advisor. Pull up the criteria for use for terzepatide. Get your MOWV program participation documented in diet, exercise, and behavior. Know your BMI and your comorbidities before you even sit down in that exam room.
And considering all of that foundational work, it raises an important question, something we actually haven't touched on yet, but it lingers over this entire process.
Oh, what's that?
Well, we have spent this whole time discussing how to get the medication approved today. We outlined the sweat equity required by the MOWV program, the dietary changes, the exercise routines, the behavioral shifts. But what happens to a veteran's medication approval if they stop maintaining those healthy habits once they secure the prescription?
Oh, wow.
Does the VA view these highly expensive medications as a lifelong subscription, or do they view them merely as a temporary tool to jumpstart a lifestyle change that the veteran is then expected to maintain on their own?
That is heavy.
Yeah.
Because if it is a temporary tool, getting the approval might only be the first half of the battle.
Keeping it might be an entirely different war.
That is a phenomenal question to mull over. Getting the key to the VIP room gets you inside, but staying inside is a whole different challenge. Thank you all for joining us on this deep dive. Keep learning, keep asking questions, and above all, keep advocating for yourselves out there. We'll catch you on the next one.
If you found this video helpful, please consider donating to helpallvets.org. Thank you.
A special thank you to MarketUS.com for furnishing us this information. You can reach them at MarketUS.com or call them at 954-636-3232. Before we go, this deep dive was created by the MarketUS.com team. Let us know your thoughts in the comments below. It's right below the subscribe link.